Today we will see the second part of this talk about the signs that we can see in thoracic imaging. And the first slide is to remind you the objective of these two talks. One of the objectives is that you can recognize important radiological signs that can be seen in any modality, CT or chest X-ray, understand the mechanism of production of the signs, and the most important, try to establish a diagnosis or differential diagnosis using the signs. We will start with the figure 3 sign, and this sign is seen like an abnormal contour of the descending aorta in the upper portion of the descending aorta, and this abnormal contour is due or secondary to aortic coarctation. And as you know, a coarctation of the aorta is a narrowing of the aorta at the level of the ductus arteriosus that is exactly here. So this is the area of the aorta that you will find the coarctation of the aorta. Immediately distal to the origin of the left subclavian artery. This abnormal finding, that is the coarctation of the aorta, can be seen in up to 10% of all congenital heart diseases, and you can diagnose using a cardio CT angio, or you can use angiography or MRI. Coarctation of the aorta could be simple, that is associated mainly in adulthood, or could be complex, that is associated with the congenital heart disease and is seen mainly in infancy and childhood. In the past, we used the postductal and preductal coarctation or terms. Right now, we are using just ductal term in order to say or to describe this coarctation. If you see the radiography of this patient, you can find other findings, like, for instance, enlargement of the cardiac silhouette, and sometimes you can see congestion at the level of the pulmonary veins. Obviously, you can see the typical figure 3 sign in the aortic arch and descending aorta, and sometimes you can see the notching or the rib notching that is scalloping in the inferior aspect of the ribs. This rib notching is seen in person or in a person older than 20 years, and normally is involving the 4th to 8th ribs. Sometimes can be seen in the 3rd or 9th, but never is seen in the 1st and 2nd ribs, because the intercostal arteries are originating from the subclavian artery and not from the aorta. So in this particular case, we can see that there is opacity in the left upper mediastinum with double convexities. Here you can see one convexity, the other convexity, and in between you have a narrowing. This is the figure 3 sign, and this is seen in cases of coarctation of aorta. This is the CT of the same patient. You can see the narrowing of the aorta. You can see the sagittal preformity imaging with the narrowing of the descending aorta, and you can see here in the MRI that there is a typical appearance of the figure 3 sign. The notching are seen here in these 2 ribs, and you can see like a minimal scalloping in the inferior aspect of the ribs. Epicardial Fat Pad Sign was described in cases of pericardial effusion and was described in 1955. And at that time was named Epicardial Fat Pad, but today we are knowing this sign as Oreo cookie sign. And you can see any time that you have a pleural thickening, a pericardial thickening or a pericardial effusion. Just to remind you the normal anatomy of the pericardium is composed by 2 different layers. The inner portion or the inner layer, that is the epicardium, and the outer layer, that is fibrous, that is the pericardium. And in between you have the pericardial space. The pericardial space normally contains up to 50 cc of fluid, and to see a pericardial effusion in the chest X-ray you need about 200 and 250 cc of fluid. The normal thickening of the pericardial sac seen on the lateral view of the chest radiograph is approximately 1 to 2 millimeters. And to understand this sign, we need to remind the anatomy. Here we have a normal case with this area, focus your sight in this area that you can see the pericardial sac, and this abnormal case with a pericardial effusion. And this is the CT of another patient with pericardial effusion. If you see here, you can delimitate the myocardium. This is the myocardium, that is the portion of the heart. Outside this myocardium, you have a fat tissue that is epicardial fat tissue. Then you have a linear opacity that is the pericardial sac that is measuring up to 2 millimeters. And outer to that, you have another fat tissue that is the pericardial fat tissue or fat tissue in the mediastinum. If you focus your sight in the other case, you can see that here you have a lucency that is the epicardial fat tissue. Then you have a thick opacity that is the pericardial effusion, and is surrounded by another hypodensity here that is the fat tissue in the mediastinum, and this is the Oreo cookie sign. So the fat tissue represents the layers of the cookie, and the pericardial effusion is representing the cream of the effusion. I have to bring some examples. Some examples. Yeah, good idea. Okay, this is the epicardial fat pad that was described in 1955. And in this particular case, with a prominent cardiac silhouette, you can see that the pericardium is separated from the myocardium because of the epicardial fat pad. So this is the original epicardial fat pad, and this is the most delicious cookie sign that is seen only on the lateral view of the chest. Obviously, we can see other findings associated with the pericardial effusion, like the loss of the retroexternal space. Remember that in the retroexternal space, you have a clear space, there is nothing, and when you have a prominent right ventricle or you have a pericardial effusion, that retroexternal space can disappear. Or you can see the water bottle configuration that is not typical, is not very specific, but in a proper clinical setting, you can say that because there is a big cardiac silhouette with a narrow vascular pedicle, you can see this particular configuration of water bottle, giving the impression that there is a pericardial effusion. Echocardiography is the study of choice in order to diagnose a pericardial effusion. You can use the CT or MRI, and MRI is used to characterize the fluid. If you have a hyperintensity in T1, so that may represent blood. Okay, Scimitar sign is another sign that can be seen in cases of anomalous pulmonary venous connection extending from the hilar region on the right side and is ending at the level of the superior aspect of the inferior vena cava. It's much more common in female, and normally the patients are asymptomatic. When there are some symptoms, those are related to infectious processes or dyspnea. In patients that are symptomatic, probably it's because they have invariably left to right shunt, or there is a severe congenital heart disease. This anomaly, that is the anomalous venous return, is associated with a hypoplasia of the pulmonary artery and the lung, and sometimes you can see a dextrocardia as a finding that is associated. Here we have a frontal view of this child with a tubular opacity surrounding the right atrium, and is extending from the right hilar region toward the abdomen and is ending in the upper portion of the inferior vena cava. In this MRI, you can see the venous that is ending in the upper portion of the inferior vena cava. And because of the particular configuration mimicking this sort, is called a Scimitar sign. Hampton Hump sign is another sign that was described in 1940. This was described in cases of pulmonary embolism associated with pulmonary infarction. And the infarction, that is the Hampton Hump sign, is a triangular opacity that is pleural based, and the apex is pointing always to the hilar region. And you can see here in this particular case that there is a filling defect in the interlobar artery on the right side, representing a PE. And here you have a minimal triangular opacity that is pleural based. The apex is pointing toward the hilum, and this is the pulmonary infarct or the Hampton Hump sign. This is the same patient 3 days later, and you can see that the pulmonary infarct is larger, and you can see that the apex is pointing toward the hilar region. Westermark sign is another sign that can be seen in cases of pulmonary embolism, and this is not very sensitive, but could be specific in a proper clinical setting. Actually, today, I saw a case with a Westermark sign in a patient with a bilateral pulmonary embolism, but the right pulmonary artery was much more involved than the left one. And what is the Westermark sign? It's hypodensity or hyperlucency of the lung, because there is a oligemia distal to an obstruction caused by the pulmonary embolism. Okay? And other thing that you have to see is the size of the vessel, because when you have oligemia, the vessels are collapsed. So if you compare the density of one lung with the other and compare the size of the vessel, and you see that in one lung there is a hyperlucency and the vessels are smaller than the contralateral side in a proper clinical setting, you can suspect that there is a pulmonary embolism. So I will show you 2 different cases. In this particular case, you can see that the left lung is more loosened than the right lung. So you can suspect that there is a air trapping disease on the left side. But if you compare the size of the vessel, you can see that all the vessels in this lung are collapsed with respect to the other side. So in the proper clinical setting, you can order or suggest the possibility of PE and suggest a CT angio that is the gold standard to diagnose this disease. We cannot use the chest X-ray to diagnose PE, but we can suggest that possibility. This is another patient that was in ICU. You can see the endotracheal tube, and you can see that there are prominent hilar region, very large pulmonary arteries, and you can see that there is an abrupt difference between the size of the vessel distally and the vessel centrally located. So because of this difference, we can suspect that there is a oligemia, a bilateral oligemia, caused by a bilateral pulmonary embolism that is shown in this PE. Fleischner sign was described by Felix Fleischner in 1961 in cases of PE. Obviously, this is not very sensitive or specific, but once again, in a proper clinical setting, if you have enlargement of a pulmonary artery, you can suspect that there is a PE that could be acute or subacute. Here we have an example of a prominent hilar region on the right side and prominent hilar region on the left side. And you can see that there is an abrupt difference between the size in the vessels centrally and distally. And we can suspect, because of this prominent hilar region, that this could be a pulmonary embolism. Hilar overlying sign is one of the signs that was described by this famous thoracic radiologist, Benjamin Felson. Benjamin Felson has described the Signet sign, that is the most characteristic sign. And also he described a lot of signs. And one of the signs is the overlay sign, that is very useful to distinguish between a mass in the mediastinum from a mass that is in the hilar region. If you have an opacity that is projecting over a hilar region, and you can see the vessel through that opacity, that opacity for sure is not in the hilum and could be located in the mediastinum anterior or posterior to the hilum, but never in the hilar region. If you see that the mass cannot be separated from the hilar structures, that mass for sure is in the hilar region. And I will show you some example. Here we have a patient with a large soft tissue mass projecting over the right hilum. But you can see very well the structure, the vessel, in the right hilar region. So for sure, this is not in the hilum, and in this case was anterior to the hilum in the mediastinum, and this is a case of a thymoma. On the contrary, we have this other example. We have a prominent hilar region with a rounded opacity here that you cannot separate from the pulmonary vessels. So this is indicating that this mass should be located in the hilar region, and in this case represent a tumor in the right hilum with a lymphadenopathy in the mediastinum. Another case, a young patient with a supposed cardiomegaly, pleural effusion, but there is an opacity here in the right upper mediastinum. This patient is very young. We don't think that this is a cardiomegaly, so this should be a mass that could be located in the hilar region, but you can see the left hilum. So if you are seeing the left hilum with the structure, that mass is not in the hilum, should be in the mediastinum, anterior or posterior. In this case, was a case of a lymphoma with a pleural effusion on the left side. Hilar convergence sign, another sign described by Felson. And it's very important to distinguish between a prominent hilum due to a mass, for instance, or enlargement of the pulmonary artery. If you see that for instance, here we have a prominent hilar region. If you see that the pulmonary arteries are converging toward the lateral side of that mass represents a prominent pulmonary artery. If the vessels are going through the mass and is ending behind the mass, that mass is not a prominent pulmonary artery and could be a mass in the hilum. In this particular case, we have prominent pulmonary arteries with convergence sign. There is a convergence of the pulmonary arteries. In this particular patient with a pulmonary arterial hypertension, enlargement of the main pulmonary artery and enlargement of the right and left pulmonary arteries. Fallen lung sign is a sign that is seen in cases of rupture of the distal trachea or the main bronchi. So when we have MBC or a fallen, when the patient fell, because there is an abrupt deceleration, there is a rupture that is a transsectional rupture of the trachea distally or at the very beginning of the main bronchi. So normally the rupture of the airways occurs in that area in about 80% of the cases. When we have this particular sign, we can see that the lung is fallen into the hemithorax. And I will show you two different cases. This is one MBC trauma with multiple findings, right pneumothorax, contusion areas in both lungs. There is evidence of pneumomediastinum, there is subcutaneous emphysema, and there is a chest tube. And beside the presence of the chest tube, the pneumothorax is not resolving. That is because the air is entering through the rupture in the right main bronchus or in the distal portion of the trachea. Here you can see the fallen lung that is felt in the posterior aspect of the right hemithorax, and this is indicating that probably there is a rupture in the distal trachea or the origin of the, in this case, the right main bronchus. Another example is this. So we can see another MBC with contusion areas in both lungs. There is a pneumothorax. Here we can see very clear the pneumothorax, And you can see that there is a rupture here at the origin of the right main bronchus, giving the fallen lung sign in this particular case. So when you have that sign, think that there is, or probably there is a rupture in the distal trachea or in the origin of the right or left main bronchi. CT angiogram sign is another sign that was described some time ago in cases of BARC, bronchoalveolar carcinoma, or invasive adenocarcinoma or mucinous adenocarcinoma that we are calling right now. What is the sign? The sign, when you have a consolidation area and you are giving contrast material, you can see the vessel in the consolidation because the consolidation has a hypodensity. And the hypodensity is because of the mucin production of the tumor. So that particular sign was described in 1990 with a 92% of specificity for that particular mucinous adenocarcinoma. But that is not true because this could be seen in cases of pneumonia. We can see in cases of metastasis from GI carcinoma. We can see in cases of lymphoma or obstructive pneumonitis. And this is one of my old cases. This is a real tumor. This is a mucinous adenocarcinoma. You can see that there are a lot of low densities within the consolidation, and you can see the vessel through that consolidation with a metastasis in the contralateral lung. CT halo sign is seen in cases of a nodule surrounded by a soft tissue opacity, a ground glass opacity, ground glass opacity. So you have a nodule and you have ground glass opacity surrounding the nodule. That sign was described in 1985 in cases of invasive aspergillosis, but you can see in many other situations. So this is not very specific for this entity, but you can see in other entities. For instance, if we have a tumor and you have a spreading of the tumor, you will see ground glass opacity surrounding the nodule. So when you have a nodule and you have ground glass opacity, the ground glass opacity could be secondary to hemorrhage, secondary to inflammation, or spreading of a tumor. So you can see right now in many other diseases, infectious processes, many other infectious processes, neoplastic diseases, non-neoplastic diseases like Wegener granulomatosis, organizing pneumonia, or even in hypersensitivity pneumonitis. So for that reason, because there are many alternatives, we have to know the clinical history of the patient to narrow the differential. If we have multiple nodules and the patient is immunocompromised, probably if we are seeing a nodule with a ground glass opacity, that could be an infectious process secondary to a patient with AIDS, and that could be aspergillosis, or could be Kaposi or lymphoma. If we have a patient with leukemia and there was a bone marrow transplantation, the patient has fever, probably that nodule with the ground glass opacity may represent invasive aspergillosis. But if you have a patient that is immunocompetent, history of smoking, hemoptysis, and there is a nodule with the ground glass opacity, that could be adenocarcinoma. So let me to show you two different examples. Here on the left, we have a nodule surrounded by a ground glass opacity, and this particular case is an infectious process, a typical mycobacteria. But this other case, that is a nodule with a ground glass opacity, this is a case of organizing pneumonia. We have the reverse halo sign, that is the opposite. So we have a ground glass opacity surrounded by a soft tissue density, okay? And that was described in 1996 to be specific of cryptogenic organizing pneumonia. You can see in organizing pneumonia, but you can see in many other cases, okay? You can see in Wegener granulomatosis, you can see in paracoccidioidomycosis, lipoid pneumonia, invasive aspergillosis. And here, there are two different examples. Actually, Justin, you have seen a case of organizing pneumonia yesterday?
Yeah.
Do you remember the case with the multiple ground glass opacity? Okay, wonderful. Well, here we have the ground glass opacity, and we can see the soft tissues surrounding the ground glass opacity. This is a case of paracoccydoidomycosis. But on the other case, we have the same finding and other ground glass opacity, and this is an organizing pneumonia. I couldn't say cryptogenic because cryptogenic is no etiology. So we don't know if it's secondary or primary. So mention organizing pneumonia. That is enough. Okay, split pleural sign is another sign that can be seen in chest CT. Cannot be seen in the chest radiograph, only in the CT. And you will see that there is a thickening of the visceral and parietal layer with enhancement with the contrast material. And this can be seen in cases of empyema or exudate pleural effusion. You can see exudate pleural effusion in cases of pneumonia, or you can see in cases of PE or in cases of cancer. And I will show you two different cases. This is a HIV patient with fluid, with air fluid level. There is a thickening of the parietal and visceral layer with enhancement, and this is the pleural, split pleural sign in a patient with empyema. On the other hand, we have this other split pleural sign with thickening of the pleural layers, enhancement with contrast material, but the patient had had a cancer in the right lung. So you can see the split pleural sign in cases of empyema or exudates, not trasudates. Tree-in-bud pattern, you are very familiarized with this, it's very common. So there are branching opacities. And this branching opacity is because the small airway is involved. Actually, this was described in cases of tuberculosis, but it's not the only case that we can see. So actually, I will give you in the future a lecture about all the abnormality that you can see tree-in-bud pattern, because this could be in the small airway. You can see in the vessel that are surrounding the pulmonary arteriole, or you can see surrounding the peribronchovascular bundle that is the intertissue. So you can see this sign in cases of infectious process, but also in other idiopathic disorder like bronchiolitis, like obliterate bronchiolitis, or you can see in cases of neoplasm within the arterioles. And I will show you two different cases. This is a tree-in-bud pattern in a patient with multiple nodularity, and the diagnosis here was atypical mycobacteria. So can be seen the same sign in tuberculosis or atypical mycobacteria. Or you can see the tree-in-bud pattern in this patient with a history of breast cancer, and we interpreted this as a metastasis in the arteriole that is surrounding or accompanying the bronchiole. Crazy-paving pattern is the combination of two different things: thickening of the intertissue, the interlobular intertissue, and the intralobular intertissue, and also you will see ground glass opacity. And because of that, you have a particular appearance that is mimicking the crazy-paving, and for that reason it's called as a crazy-paving pattern. This was described to be a specific of PAP, alveolar proteinosis, but that is not true because you can see in many other diseases. Infectious process like pneumocystis jirovecii pneumonia, you can see also in bacterial pneumonia, mycoplasma pneumonia, you can see in cases of neoplasm like mucinous adenocarcinoma, you can see in cases of sarcoidosis, organizing pneumonia, NSIP, or you can see when there is inhalation like lipopneumonia, or in, there is blood within the alveolar space. This sign in the English literature is known as a crazy-paving pattern, but in Spanish, this is known as a cobblestone sign. So you can use either one. But in English, it's much more common to use the crazy-paving pattern. And this is the crazy-paving pattern in a patient with a PAP. So anytime that you have a PAP patient, you will see this opacity. But could be other differential or other diagnosis. Just this example. Here is a patient with a multiple interstitial prominence and ground glass opacity and thickening of the interlobular septa and intralobular septa, and this is a patient with the NSIP. NSIP because there is a diffuse extension of the process from the top to the bottom. Comet sign, this is for you, Luis. We were talking about the rounded atelectasis, okay? So Comet sign is seen in cases of rounded atelectasis. Rounded atelectasis is a particular shaped atelectasis because there is a torsion of the lung upon its axis and giving an appearance of a rounded opacity. When we have rounded atelectasis, there is always an associated chronic pleural disease. So that is a sine qua non condition. You have to see a chronic pleural disease with pleural effusion or not, with pleural plaques or not, with calcification, with thickening of the layers, but you have to see that. Here we have an opacity that is very pleural based, and you can see that there is a torsion of the vessel and the bronchi because there is a chronic pleural disease on the right and on the left, and this particular opacity with this particular shape of the vessel and the bronchi extending from the subpleural area toward the hilum is called the Comet sign and is very typical to see in a rounded atelectasis. And this diagnosis is very important because when you have a rounded atelectasis, you can mimic, or this can mimic a tumor. Actually, if you are giving a contramaterial and on the CT, you will see enhancement because there is a collapse of all the vessel. If you are ordering a PET CT, will be positive because there is an inflammation over there. So the only way to differentiate between a rounded atelectasis from a tumor is to see this type of sign. So for that reason, it's very important. And lastly, but not least, we have the Signet ring sign that is seen in cases of bronchiectasis, and this sign is seen in CT or high-resolution CT, and you have to remember the anatomy. At the level of the small airway, or centrally, we have a bronchus and an artery. And distally, we have a bronchial and arterial, always. So when we have a dilatation of the airways is much bigger than the artery, and the relation is greater than 1:1, because normally the relation is 1:1, so the same size for the pulmonary artery or arterial and the bronchus or bronchial. When you see that the bronchial is larger than the artery, you have a bronchiectasis. And you will see a ring-like appearance, and you will see a dot surrounding or adjacent to the ring-like appearance, like this. Here we can see a dilated broncho or bronchial with a pulmonary artery adjacent. So anytime that you have this configuration, you can say that there is a bronchiectasis. And this is very important because sometimes bronchiectasis can mimic a cystic lung disease. The difference is in the cystic lung disease, you don't have the pulmonary artery that is adjacent to the ring-like. Okay, so this is the picture of the Signet ring. And this is a bronchiectasis with the typical appearance of the bronchiole that is dilated and the rounded opacity adjacent to it. So I think that is more proper. The proper name should be per ring sign because it's mimicking this particular ring. So in conclusion, it's very important to identify these signs. It's very important. It's identification of these signs can aid you to do a better diagnosis. Sometimes can indicate what could be the next step. For instance, if we have a prominent hilar region, we have oligemia in the lung, and we have a patient with tachypnea, and the patient has a vascular disease in the pelvis, we can think that probably there is a pulmonary embolism, and you have to suggest the next step, that is the CT angio. So knowing this sign is very important, because you can recommend the next step, and this promotes improved patient care. Okay, thank you very much. I don't know if you have any question or comments about the signs. So was a little different between this case and the case that you showed?
I really thought that I had this round atelectasis in the morning. I was going to call it round atelectasis.
Okay.
But yeah, it's hard to say. It's
Yeah.
hard to tell.
And respect to your case, it was typical. So
Yeah,
there was a lot of
the whole lung.
bivascular rounded areas with current glass opacity and the soft tissues surrounding that particular area. Yes. Ladies first. Are you agree? Oh, thank you.
Thank you. Dr. P, the Comet sign, you said it's seen in round atelectasis?
Yeah, rounded atelectasis.
Rounded atelectasis only when there is chronic pleural inflammation?
Yes, because rounded atelectasis is seen in cases of chronic pleural disease.
There is another thing that looks like round atelectasis, like a rounded pneumonia in kids. That is not associated with any chronicity, right?
No. Actually, rounded pneumonia is not very common to see in adults.
Yeah,
It's much more common in kids.
Yeah.
Actually, one of the cases that I love to show the resident is a rounded pneumonia in a patient.
It doesn't have to be pleural based right there.
No.
There's no association with pleural abnormalities.
Yeah.
This requires.
No.
I think there's 5 diagnostic criteria
Yeah.
necessary for
Yes.
No, there is.
Yes, that is true. Listen what Dr. Gates said. Initially, rounded atelectasis was associated with asbestosis, just asbestosis, but that is not true. So asbestosis could be one of the reasons of the rounded atelectasis.
I think there's a lot of things I can do.
So remember,
When I was a resident, that was your very first thing was asbestosis.
yeah.
Asbestos.
Remember that asbestosis is a interstitial lung disease. It's not a pleural disease. Okay, so you can see some pleural involvement, and it's asbestos-related pleural disease with pleural effusion, just pleural effusion, thickening of the pleural, focal, general thickening. You can see pleural plaques. You can see calcification of the pleural plaques, but it's a interstitial lung disease.
And the most common cancer with asbestos is run-of-the-mill bronchogenic carcinoma.
And
Mesothelioma. That's
yeah.
the one that's specific for it, but you're much more likely to get bronchogenic carcinoma. If you smoke, exponentially increase the risk.
Okay.
Excellent.
Thank you, sir.
Thank you very much.